I have the honor now, I'm Josh Bauml, I have the honor to introduce Dr. Joshua Sabari from NYU, and we're going to talk about less common targets, RET, MET, BRAF, but the goal here is to sort of be inclusive of other targets. And so Dr. Sabari is going to be speaking, give a whole lecture on this in a little bit, but in the meantime, I thought we could address questions that people might have through the streaming or in the room.
All right, and if there are no questions, I guess we can also have an open discussion about each of these targets and sort of what's on the horizon and where the field is moving.
Absolutely. Do we have any questions to begin? So what do you think about the emergence of RET? Are you testing all of your patients for RET, and if so, how are you doing that?
Yeah. So that's a great question, and I think the RET rearranged field is a fascinating one, and it's one that we're identifying more commonly in patients as we continue to look for it. So RET is a fusion. It's actually pretty rare. It occurs in about maybe 1 to 2% of non-small cell lung cancer, most commonly adenocarcinoma. And it's mostly seen in folks who have never smoked. We do not test for FISH for RET, and we don't do IHC. I don't think there is a great IHC actually for RET, but we do next generation sequencing on all patients, both in tissue and in plasma. There are some difficulties with identifying RET in NGS, especially DNA-based NGS testing or next generation sequencing. So there are some other more advanced tests that we do, especially in folks who we have a high, pre-test probability that they may have a driver. Are you guys testing for everybody?
Yeah, so everyone with adenocarcinoma, we do a DNA-based NGS and an RNA-based fusion panel, which is what we call an Archer platform. Right. It's multiplex PCR for the pathology people in the audience, but for the purposes of a patient's perspective, it is a multi-target analysis that is better at detecting fusions, given some of the limitations of doing DNA-based NGS.
So just briefly, the Archer Fusion Plex is basically a test that individually looks for a specific fusion. So you have some a priori knowledge about the fusions, and you're attempting to identify them. And we do that as well, but we tend to use it on patients when we know we don't identify any other drivers, given cost and sort of access. So the RET fusion field has been fascinating. So really initially the first publication to come out was in 2013, showing that there was activity for a drug called cabozantinib. Now, have you used cabozantinib at all?
I have not, and I don't intend to.
How come?
It is enormously toxic. The rate of rash as well as mucositis is quite limiting, and we've been rather spoiled in the lung cancer field because our targeted drugs tend to be rather well tolerated.
Right, and I agree. I don't use cabozantinib either, but I think it was the first sort of step to show that we have activity, or you have some RET, activity from a tyrosine kinase or a pill that you can take to treat the cancer. So what types of drugs are you using in the clinic now? And I guess before we talk about the RET-specific inhibitors that we have, what kinds of drugs were you using in the last 2 to 3 years?
So the last 2 to 3 years, I was referring completely for clinical trials. I mean so we were lucky. We have a rare tumors program at Penn led by Dr. Brose, and so we've had access to both Blue 667 and Loxo 292, which are these RET specific.
Great.
Drugs.
So I think that's where the field is moving, is really not to use these, we call them dirty tyrosine kinase inhibitors or dirty medicines because they block multiple different areas. We're really moving towards very specific RET inhibitors, and as you mentioned, Josh, Blue 667 and Loxo 292 are definitely the two sort of leaders in the field there. So I want to talk a little about the data. Both of those have been presented at ACR and then at ASCO last year, and really, really exciting data.
Yeah, so the response rates are very, very high, often higher than 80% that we're seeing. And in addition to that, the toxicity profile is really, really good. So RET translocation, I obviously advocate for clinical trials, given that's what I do. But RET translocation is one of these situations where I will tell a patient if they don't have access to clinical trial, they should get on a plane. Yeah. And I recently did have a patient who had a DNA-based NGS, which showed nothing, and then I actually saw on a liquid biopsy the RET translocation, and we put him on a trial, and very rapid response with pleural effusions drying up. I mean, this is really dramatic, and it makes a big difference for patients' lives.
Yeah, and I agree. I think both of those RET fusion inhibitors are very well tolerated. we have the LOXO study open at our center, and I met about 2 weeks ago now a young woman, 36-year-old, never smoker, EGFR ALK negative by immunohistochemistry, and we did the fusion plex and as well as the DNA-based assay only because we had such a high pretest probability in her, and we did identify the RET fusion. She was enrolled, actually started drug, and had improvement in her symptoms within a few days, which is really, really impressive. Moving forward, how do you think these two drugs are going to pan out? Blue 667 versus LOXO 292. Any early signals or?
I don't think we have much to really compare them on. I think they're both very active drugs. They're both very well tolerated, and they actually seem to be going on the same sort of path. I think we'll probably have access to both of them at a pretty similar time.
I agree. I think it's exciting that we have two different drugs in this space. I think it's great for patients. I think one of the interesting things, or two of the interesting things to think about, is how well do these drugs, work over time, so the durability of response, and sort of what resistance mechanisms develop, meaning, how can the cancer sort of outsmart this drug, or what abnormalities can develop in the cancer where the drug no longer has great activity. And I think, we still don't know, or we don't have all the information yet, and I think that'll pan out over the next, hopefully, many years, right? The longer patients are on these drugs, the better for them.
But it's a similar story to in endtrack, which is another translocation, which is very rare, even rarer, across multiple tumor types. We saw at AACR last weekend that there's already a next generation inhibitor for patients who become resistant to a first generation endtrack inhibitor. And that's pretty remarkable when you consider how rare the target is, that we have scientists who are really leading the way and identifying those resistance mutations and developing drugs to target them.
No, it is fascinating, meaning that before we even start with the drug, we have preclinical information or preclinical data to sort of understand what resistance mechanisms may emerge, and then we can actually predict and maybe see them in patients. And to have the next drug available, that's phenomenal for patients.
Yeah.
What about intracranial response rate? What that means sort of in English is a lot of times we worry about this cancer moving from the lung to other parts of the body and maybe spreading to the brain. And RET, rearranged or RET fused cancers commonly do that. So what do you think about these two drugs, Blue 667 and LOXO 292? How's the response been in the brain?
I believe both of them do get into the brain, which is very, very helpful. Because as you're absolutely right, this is a major site of resistance, and once patients develop brain metastases, that's highly problematic because radiation to the brain is very toxic, and being able to control these things with a pill is much easier.
Right. And I think, I agree, both of these drugs have phenomenal central nervous system or brain penetration, and both drugs in their presentations have reported, good response rates in the brain. I think we do need to see further data further out, especially duration of responses is interesting. The other thing that's interesting is, even beyond RET-directed therapy.
Doctors Hegde and Sabaya, who were two of the leaders in terms of looking at RET translocation down at MD Anderson, and they compared outcomes for patients who received immune checkpoint inhibition as opposed to patients who received a RET inhibitor, and the RET inhibitor was way better. And one of the reasons why, and this probably goes across multiple targetable alterations, is that when someone has a target, their tumor mutation burden is lower, their degree of immunogenicity seems to be lower, and so as a result, their response to immunotherapy is also lower. I think chemotherapy still works, and we've seen with EGFR and ALK that chemotherapy has efficacy, but I still would strongly favor a good TKI over chemo.
And I agree. I think, it's critical, and I tell all my patients when I meet them, if we identify a driver like RET fusion, for example, you always want to exhaust all of your targeted therapies first before moving on to any other treatment. And we had a small series looking at response rate to immunotherapy in patients with RET-fused lung cancers. And as you mentioned, I'm not sure that immunotherapy has a great role in RET-rearranged cancers as single-agent immunotherapy, but perhaps in combination, we don't know. It's not been studied. And Josh, like you said, chemotherapy actually does work very, very well in RET-rearranged lung cancer. There's actually a really nice paper by one of my colleagues, Dr. Drillon, Alex Drillon at Memorial Sloan Kettering, showing that response to pemetrexed, or duration of response, is about 18 months, which is impressive. So there are other drugs available that are not specific to RET that are there if the RET, tyrosine kinase inhibitors are no longer working. But we hope that, the companies will continue to develop and will continue.
In terms of this space, can you touch a little bit about that?
Sure. So MET exon 14 is another rare alteration. You probably see it about 1 to 2% in patients with non-small cell lung cancer. Interestingly, about MET exon 14 is in certain subsets of lung cancers, like sarcomatoid lung cancers, for example. You see it in a lot higher percent, probably about 20 to 30% of patients. And if you look back, actually, Alice Shaw did the original study using a MET inhibitor, specifically, wasn't for MET exon 14, but was for MET patients in general, and the drug is crizotinib. And actually, overall, crizotinib was not a great MET inhibitor. But patients with MET exon 14?
Yeah, absolutely. So a patient who has MET exon 14 skipping mutation, I do give crizotinib preferentially. The issue there, of course, is that unlike some of these new RET inhibitors and unlike some of these other new TKIs, crizotinib doesn't do a good job of getting into the brain.
Seeing in the other alterations. But again, it's the option that we have that's available. There are other MET tyrosine kinase inhibitors in clinical trial right now that are ongoing. But the question that you initially asked is, what would you give a MET, tyrosine kinase inhibitor like crizotinib? Again, crizotinib has other activity as well, but for MET exon 14, we're using that portion, or chemotherapy or immunotherapy. And I think the jury is still out. Our group combined data with Dr. Mark Awad at Dana-Farber, really looking at how people have done on immunotherapy who have MET exon 14 alterations. Mutational burden, it seemed like they did better than the patients who were never smokers that had low tumor mutational burden. I don't know if that would pan out in a prospective clinical trial. Again, these are all retrospective or sort of taking a look back at data that we already have.
Is a mutation that can be seen in patients with lung cancer with a rather substantial smoking history. Sure. And so I wonder if the driver there is not so much the presence of an alteration, but the association of that mutation with other features that lead to a relatively immunosuppressive environment.
No, I completely agree. And that subset of patients, the immunotarget, led by Julie Mazieres, was really a Herculean effort on his part. He had reached out to our group and others, probably, looking at, can you, submit your patient information, obviously be identified and IRB approved, so we can actually study it. And that's a huge problem in these single driver altered cancers, is that even at large academic centers, you might only have 15 or 20 patients with a specific abnormality. So by him joining information with multiple institutions, he was able to acquire data on about 500 patients. Granted, most of them were KRAS altered, so the data there wasn't as exciting, but there were about 200 patients who I think were very, very interesting to look at. Again, retrospective data, we do need more prospective studies. I'm not sure we're ever going to see them, though, in this patient population.
So not specific to MET and RET, but I currently am leading an effort through Atomic, which is the an academic thoracic oncology medical consortium, which is run by Dr. Ross Camage. And so what we're doing with that is trying to identify mechanisms of resistance amongst patients with EGFR, ALK, and ROS1 alterations. But part of that is we're going to be collecting all of their treatment data. And so we'll be able to have some information about response to immunotherapy and things like that moving forward once we get that data.
And that's critical, actually. I think, we can give drugs to people and people can take drugs to treat their cancer. But if we're not understanding why those drugs are working or not working, we're actually doing a disservice to our patients. And, Ivy Elkins and Jill Feldman are in the room next door, and they have, single-handedly led, sort of drives for patients to donate or give tissue on protocols so that we can study this tissue and better understand resistance mechanisms. And Josh, I know you're part of a lot of those programs, and I think it's so critical that patients understand and know that by allowing us to study tissue and understand the resistance mechanisms, we can then look at new approaches and the development of new drugs.
Yeah, it's absolutely essential, and it's a real honor to be able to work with patient advocates and patients to move this field forward, to say that it's not only the scientists or the professors in the ivory tower that are doing this work. This is really affecting patients' lives, and so we need to know what we have to do to help the patients. What do you think about BRAF? Now, this is something that we've heard in melanoma, but BRAF.
specific alteration, V600E, for a while, as you said, in melanoma, but is also in colorectal cancer. You're right, it does occur in lung cancer as well, also at a relatively low frequency, about 1 to 2%. And there have been many, many studies now looking at FDA-approved drugs in other diseases in lung cancer. And I do believe now we have an FDA-approved indication since 2017 for trametinib and dabrafenib. Now, I think the problem with those two drugs is the side effects. And, we do talk about, tyrosine kinase inhibitors or, here RAF inhibitor, for example, and a MEK inhibitor. And we, speak about the response rate and we speak about sort of, durability. But really, I think, we have to look at, how well are these drugs acting on the target and are they causing any off-target toxicity? So for BRAF, for the RAF inhibitor and the MEK inhibitor, it is what we commonly, sort of prescribe in the frontline setting. But what sort of toxicities are you seeing? And do you think we're doing a good job in that sense of can we do more and can we develop better targeted therapies for these patients?
So the BRAF inhibitors, when given by themselves, can develop skin cancer. That can lead to the development of skin cancers. The combination, people can feel pretty crummy. They can have fever and just sort of feeling fatigued. In my experience, it's better tolerated than giving chemotherapy,
Agreed.
but
Agreed.
it's not as easy as giving someone something like the Blue 667 or something like
Agreed.
that. The other issue with BRAF is that actually I find this very surprising, despite the fact that we have used BRAF inhibition in melanoma, and a lot of people have been doing this. I would expect we'd have a lot more information about mechanisms of resistance there than we do. We really know very little. And the other unique thing about BRAF in that setting is that it seems to be just V600E.
Correct.
Right? And that's different from melanoma, where other BRAF mutations may respond. In lung cancer, if they don't have V600, or it doesn't have necessarily be V600E, but V600, giving these drugs is the wrong move.
Sure.
Right?
Yeah, no, I agree. And I think there are many open studies that are looking at RAF inhibition and other mechanisms of inhibition. But so far to date, I have not seen any, profound or great data. So one of the problems with all targeted therapies, for example, is folks do develop resistance over time. And in the BRAF space, unfortunately, we don't have any great approved agents in the second line setting. I just recently had a young woman also in my clinic who I was taking care of. I inherited. And unfortunately, she progressed on, dabrafenib, trametinib. What would you recommend in the second-line setting in somebody who has BRAF V600E mutation?
So I go back to standard of care, which is chemoimmunotherapy.
Yeah.
If they're PD-L1 overexpression, perhaps immunotherapy alone. But I think that in the BRAF mutant setting, I would be more likely to use chemoimmunotherapy. What's interesting is I have a case that I'm treating right now who was on a chemoimmunotherapy study, randomized to chemo, and has a BRAF and PD-L1 overexpression.
Wow.
And BRAF is one of these rare situations where if someone's PD-L1 overexpressed and they have ALK translocation, or PD-L1 overexpressed and they have RET, I'm giving them the TKI. Someone is BRAF mutant and PD-L1 100%. I don't know the right approach there, particularly if they have a heavy smoking history.
That's right, yeah. So the patient I'm talking about that I'm seeing now is a never smoker. So,
Okay.
I did talk to her about chemotherapy versus chemo and immunotherapy, and she really opted to take chemotherapy and immunotherapy. And just to make a point here for the people that we see in the clinic, it always amazes me how everybody wants to take whatever they can take to feel better and live longer. So I think we owe it to our patients to try to find the best combinations and the best drugs with the least amount of toxicity. I think the BRAF space, there is no clear-cut data in the second-line setting of what the best regimen is. So I struggle with this in clinic with my patients as well.
Yeah. Are there any questions from the World Wide Web? Hello.
Hello, guys.
Hello, people who are saying hi. There are no slides for this. The goal was that we were going to just have a discussion.
So let's talk a little about endtrack, because you mentioned it earlier, and it is a really exciting space. And the reason I bring up endtrack is a lot of people are concerned that maybe we're putting lots of efforts into a disease or a fusion where you don't capture lots of patients. And how do you react, or how do you respond to those people who sort of second-guess efforts in developing drugs and very small or narrow niches of patients or people.
Well, I think the whole understanding of targeted therapy is built around personalized approaches. And I think that as long as that is done in a cautious fashion, it's appropriate. I think that if we do next generation sequencing and identify things and start giving drugs that are inappropriate, that's going to cost a lot more than doing just the testing. When we do the testing and identify the correct target and give a drug for that target, I think that's a very good thing, certainly for the patient, and from an efficiency perspective, is also very good. And I think that once you see these responses that occur, it's hard to be dubious anymore, right? So like it's the sort of thing where, you spoke about how rapid the responses are. I tend to tell my patients, you feel sick right now, I'm going to give you this pill, you're going to get it in a week, and you're going to feel better in a week and 1 day. Yeah. And that's what we see. It's really amazing to watch. And I think that it sort of calls into mind I think there are negative things that can be said about next generation sequencing, but when used appropriately with an actual target, it works.
Yeah. So I completely agree. I think that, yes, it is costly, but at the same time, when you're talking to a patient or a person in your office, and there is a high pretest probability that you're going to identify some driver, and you have drugs that work on those alterations, I think it makes sense to develop them. I think we have to be cautious, though, of how we use this testing and how we use these medicines, because we want to make sure that we're giving the right medicines to the right people. And I think that's critical, and you definitely hit on that. I want to bring up another controversial topic. So, Josh, you're prolific on Twitter, which is really, really impressive. And I saw a beautiful feed on the tumor mutational burden.
Yeah.
So if you could, talk about what that means and sort of what does it mean to patients who have targeted altered lung cancer or actionable alterations in their lung cancer? Does that fit in there or not necessarily?
Well, so tumor mutation burden, if I can get up on my soapbox, but then they'll have to change the camera height. So I'm going to not get on the soapbox. So tumor mutation burden is a biomarker of response to immunotherapy. We've known for many years, actually through a lot of work that's come out of Sloan Kettering and other institutions, that tumor mutation burden, as measured by whole exome sequencing, everything in there, all the exons, that is associated with response and better outcomes on immunotherapy. And the reason why that might be is that when there are mutations, that makes what are called neoantigens, which are these funny-looking things to the immune system. The immune system gets excited and it attacks it.
Yeah, it's sort of the cancer looks different than your normal cells in your body because there's different amount or more amounts of abnormalities in it.
So now that is being taken out of the whole exome sequencing, and we're getting TMB from next-generation sequencing assays. So it was already a surrogate of neoantigenicity. Now we're taking a surrogate of that and taking from next-generation sequencing. We know from whole exome as well as NGS data that the TMB of patients who have targets is much lower than it is for other patients.
Sure.
I view TMB at this point as a research test. I do not use it clinically at all. If someone comes in and they have had an NGS that spits out the TMB at me, I skip over it just like I skip over many other sections of the report because I don't use it.
Right.
It doesn't actually affect my decision making, and so I don't find it to be helpful. There was some data, more data keeps coming out, say, in this immunotherapy, high TMB is associated with better outcomes. That's not a new piece of information, and we have yet to see a study in which a priori, at the time of entry, if your TMB high, that you're going to have a higher overall survival if you get one regimen as opposed to getting another.
Yeah.
And
there was a very interesting study that just recently came out, one of my former colleagues, and they looked at, about 30,000 people with all different types of cancer, and they looked at their mutational burden, meaning how many mutations were in the cancer. And interestingly, the patients who had the highest 20th percentile of abnormalities or mutations in their cancer actually did better and lived longer. And what I extrapolate from that is maybe just having a higher tumor mutational burden, those people do better overall. And I agree with you. I don't think it's a predictive biomarker of response to any particular therapy. And I think that's the important point to make. I don't skip over the TMB so quickly. I do look at it, I think about it, and then I turn the page.
Yeah,
I
so
agree.
you read it, and
Yes.
then, okay, that's fair, but you don't make a decision, basically.
No, I agree. I do not use tumor mutational burden as a predictive biomarker for my patients. There was a study looking at 2 different immunotherapy drugs called ipilimumab and nivolumab presented last year at ACR, and that study suggested perhaps that if you had a high level of TMB, you may have a better response to those 2 drugs. And what was really exciting about the study was patients who had low PD-L1, which is our predictive biomarker of response, negative, right? 0. Those folks did better if they had high TMB. What happened there?
So the thing is that TMB and PD-L1 are what we call orthogonal biomarkers. Having a high one has nothing to do with the other one. And so it's basically like saying that, well, this is the person's shoe size, but what size gloves? Size gloves do they wear? Sure. Oh, I guess gloves and shoes.
Gloves and shoes are probably
might be related.
Yeah.
Gloves
Belt.
and belts.
There you
gloves
go.
and belts. Gloves and hat. Right?
Fair.
Like these are not related. And what it has to do with, in all likelihood, is that PD-L1 is a measure of the interferon activation, the immune system. I'm waving my hands here. The immune system activation in the tumor, whereas TMB is a measurement of the neoantigenicity. So different sides of the same coin. What we've seen in multiple analyses is, okay, if you look at high TMB and high PD-L1, those patients really do well.
Right.
Sure, they do. That's 20% of people. And so when you see that, you have to look at the other 80% who are either low, 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 high, or high, low, and they all do the same as each other.
Correct. And that was the unfortunate thing about that study presented last year, is that the data didn't actually pan out moving forward.
And the overall survival data did not show any improvement as a function of TMB.
Correct, yeah. And bringing this discussion back around to the point of the sessions today, I actually do not use tumor mutational burden as any biomarker at all in the patients or in people that I see who have single driver altered lung cancers. And actually, if you look at folks with EGFR and ALK, for example, or ROS1 or BRAF, maybe we'll exclude BRAF because that might be a little more complex, but in cancers that develop in folks who have never smoked, in general, the tumor mutational burden is very low.
Yeah.
Would you agree with that?
I would agree with that. And I would take it one step further, is that if I have a patient with EGFR or ALK, I also ignore their PD-L1.
Yeah, agreed as well.
Because I don't think that it means as much. And you're right, I don't ignore it. I read it, and then I don't do anything with it, which to me is ignoring it.
Right.
We have a question? Great. Fantastic. So the question for the
Josh happens
audience.
to be an expert in MET we work on a study together, so please, Josh, take it away.
So MET amplification, the question is, so MET amplification can occur in multiple settings. MET amplification can be a mechanism of resistance to EGFR-based therapies, and there was just 2 great presentations which were at AACR, which were by Dr. Sequist just last weekend, showing that combination of a MET inhibitor with osimertinib led to improved outcomes for those patients. MET amplification can also be seen at diagnosis. And there was actually a presentation that was done last year at the World Conference on Lung Cancer in Toronto, which showed that for such patients, giving crizotinib actually leads to responses at a pretty similar rate. The problem with MET amplification is what it means and how to measure it.
Agreed, yeah.
So it can be most classically measured with FISH, fluorescent in situ hybridization. However, most physicians are not separately ordering MET FISH. Most physicians at time of resistance, if they're doing repeat resistance testing, are doing next generation sequencing. And the sensitivity of NGS for detection of MET amplification is not great.
Yeah, I'll give you a great example. I had a patient probably 2 months ago now who I was trying to talk to them about a specific study that I thought would benefit them. They were a patient who had an EGFR mutation and then developed MET amplification as the resistant mechanism, which we see, I think, in the published literature probably about 25 or 30% of the time. Now, when I went to measure it in the blood and the plasma, I got one level. When I measured it in the tissue, I got a different level. And then I decided, hey, let me check the plasma again. And the patient did not change any therapy, and we didn't measure it at all. It wasn't identified. And then not until doing the FISH were we able to see a sufficiently high enough level where the patient would be a candidate for this specific trial that I was thinking about. So I agree with you. I think it's very difficult to measure MET amplification, and we also are not sure what is the cut rate, or what's the point where a specific drug has activity. Is it greater than 6 copies or 3 or 1? We don't know.
Yeah.
And to extrapolate a little bit from the breast cancer space, we have the same problem in a gene called, or a mutation called HER2. And there's a lot more data and a lot more literature there. I think if we move to a immunohistochemical, that's sort of where you paint the slide and then look at it under a microscope, perhaps we might be able to more easily define who is, MET high, MET intermediate, MET low.
But it's hard to know if that's the real target. So, for
Correct.
instance, when we speak about HER2, there was a very interesting study which came out of Dr. Bauml's group, and I don't know if you were on that paper.
No, he didn't put me on it.
All right, well, anyway, that was looking at a drug called atotrastuzumab emtansine. I often say that as an oncologist, one of our major jobs is saying impossible words quickly.
I call it TDM1 because
Right.
it's a lot simpler, and
Right.
I'm from Brooklyn.
So atotrastuzumab emtansine, I'm just showing off now. So they looked at this in HER2 mutant and amplified non-small cell lung cancer, because that also occurs. And what they found is a very elegant paper. They did HER2 immunohistochemistry, they did HER2 FISH, they did HER2 mutation testing, they did HER2 mass spectroscopy, where they really just put it through a machine and measured how much HER2 is there.
Right.
And the thing about this drug is it's a big molecule. And so my pre-testing hypothesis would be that it would only be what's on the surface that matters. And what they found was that it was only the mutation that led to responses with this drug, and not staining on the cell surface.
Sure.
And so I think it really is humbling, because you say, oh, well, this is what the science would say based on my understanding, and then you go and you look and say, no, I was just wrong.
So we were scratching our head with that result too. I don't think we have a great explanation there. And,
Yeah.
And it is humbling to say, what we predict up front might not actually be what's right. And maybe we're missing part of the story as
Yep.
well. Any other questions from anybody in the audience?
All right. All right. Well, fantastic. Let's see. Should we talk about HER2 a little more, do you think?
Sure.
Fantastic. Why don't you walk us through a little bit about that?
Sure. So HER2 is an alteration, again, seen at very low rates in lung cancer, maybe a little bit higher than the other alterations that we were talking about. And, I think for HER2 altered lung cancer, we don't have anything FDA approved, but as you mentioned, the Bauml study that came out about last year, I believe, or 9 months ago, using atotrastuzumab emtansine. Did I say
You did a
correctly?
good job. You did a really good job.
I practiced in the shower this morning. No. We saw about a 40, I think, to 45% response rate there, but unfortunately the durability or duration of response was low. Unfortunately, it was only about 6 months. That means how long were patients on the medications before the cancer started to grow on the pictures of the scan? So despite it being a huge move forward in lung cancer, I don't think it's going to be a sort of drug that we're, depending on, like we talked about LOXO-292 or Blue 667. So I think we need new strategies and different strategies to sort of, look at how to better target HER2. What is your standard sort of recommendation to a patient who comes in with HER2? Because I think still we're recommending either chemotherapy and immunotherapy, or going on a clinical trial. And there are actually some very interesting clinical trials that we could talk about.
So we don't have a clinical trial open right now for HER2. So I'm giving in the first line, I am giving chemoimmunotherapy or immunotherapy as would be appropriate based upon their PD-L1 status. However, I have had multiple patients with HER2 mutation that I have given atotrastuzumab emtansine to outside the confines of the clinical trial. And the reason what I found is that the response rate is not fantastic, but the rate of stable disease, I've had patients on this drug for 9 months, a year, and it's pretty well tolerated.
Right.
The big one you have to look out for is heart, right? So you got to follow with echocardiograms. but it's well tolerated, it's not too frequent, and I've had some good outcomes on it. But I think you're right, we do need better data. You want to talk about some of the emerging agents?
I'll talk first about older agents. So I have a few patients who I'm treating in the clinic now, and I've used drugs like afatinib, for example, with minimal response. I've also combined afatinib. Afatinib is a tyrosine kinase inhibitor, usually used against EGFR, so we see some activity. I've also combined afatinib with cetuximab, interestingly, and I've seen some activity. There are some reports out there. Again, the toxicity is high, so it's a tough drug to tolerate. But again, when you don't have other targeted therapies, or if you use other targeted therapies, I think before jumping to chemotherapy or chemotherapy and immunotherapy, depending on the discussion with the person in the room, you may want to try other types of agents. I don't have a specific HER2 study that I'm excited about. I have, I guess, one for HER2 exon 20, a drug called poziotinib. It was developed actually a long time ago for EGFR and had pretty good activity, but unfortunately a high level of toxicity. More recently, colleagues at MD Anderson, John Haymack, looked at screen. So actually, let's take a couple of steps back. Why is it so hard to block HER2 exon 20, for example?
So exon 20, I believe it's the way it gets into
Correct.
so I'm not a basic scientist.
You're not a medicinal chemist?
I'm not a medicinal chemist. I don't want to claim to be one.
We know how to say the drug names.
Really good at saying words. So it's hard to get the drug into the target because it's a tight space.
The binding pocket is tough, exactly as you said. So what they did is they did a very elegant experiment, actually a screen where using a computer model, they actually tested the fit of different drugs and whether it was able to fit into that pocket. And they actually identified this old drug had very nice fit or activity in a simulation. And then they tested it in cell lines, and then they tested it in animal models. And it was a really beautiful presentation and then publication showing activity both in animal models but also in humans. About 11 patients, 7 out of the 11 patients had a very good response. And given that study, they have opened a larger study called a phase 2 study where we're actually measuring efficacy of this drug, poziotinib, in that specific patient population. I think some of the issues with the drug are duration of response. So they presented it recently at the International Association of Study of Lung Cancer. I never get that right. IASLC. Can you say that?
I don't understand how it becomes ISLAC.
I don't know.
When the A is before, anyway.
We'll talk about that another time. But at that conference, they presented the median duration of response, or the progression-free survival, I should say, and it was about 5.5 months, if I remember correctly. Again, good activity, a good response rate, but the durability of the drug was small. Now, I think seeing the drug in clinic, though, there is some toxicity related, like rash, like diarrhea. So it's very important to talk to your patients up front about sort of the side effects and the toxicity of these drugs. Whether I think it has a place moving forward, I hope so. I hope we develop better drugs that have better activity in that space with less toxicity. So, actually developing a specific inhibitor would be ideal. And I think people are working in multiple companies and academic partners are working on it.
And I think that it's important to remember that chemo is not a dirty word.
Correct.
Right? So when we have patients, they're like, oh, I want to get targeted therapy, I want to get immunotherapy, I don't want that chemotherapy. When you think about some of these combinations of targeted therapies or even combinations of immunotherapies, there's substantial toxicity that can occur. And so we need to remember that if we compare that to some of our chemo regimens for adenocarcinoma, giving carboplatin pemetrexed is generally really well tolerated.
Agreed.
And so recognizing that fact and discussing these side effects with the patient in an open discussion, I think, is important, and going in with an open mind.
Right. Josh, in your practice, if somebody's on a tyrosine kinase inhibitor, a pill that specifically blocks the mutation or alteration in the cancer, and unfortunately their disease is progressing, say after 2 years, do you ever add chemotherapy to the pill, or do you always stop the pill?
So most of the time I do stop the pill, and that's based on a study that was done in Europe and Asia where they looked at this and found that continuing gefitinib, an EGFR tyrosine kinase inhibitor, was associated with impaired survival. Now there's some issues with that study.
How do you describe that, impaired survival? With, is it toxicity, you think? Or?
It was very surprising. And so I think that one of the reasons why now I'm more apt to continue the pill, in contrast to gefitinib, drugs like osimertinib, alectinib, they're better tolerated, but also they get into the brain, and chemotherapy doesn't. And so that is a reason why I have continued. If someone has known brain disease that's well controlled on a pill, then I say, well, if I'm adding chemo, I don't want to pull this away because that's keeping the brain under control.
Yeah, I agree. That data with the gefitinib was a little bit head scratching, and some of the people I've trained under sort of said, don't believe it, and it's hard not to believe prospective data.
Yeah, it's a clinical trial.
But I think that in my practice now, I agree. If someone's on Tagrisso and they're having progression of disease, especially if they have brain metastasis, and I'm not able to identify any other resistance mechanism, I do sometimes continue the pill, the Tagrisso, with chemotherapy. And generally, it's actually been pretty well tolerated. We do need, prospective clinical trials to better understand that. But again, having the discussion with the person sitting in your office is critical.
But what you should definitely not do is continue the pill and then add chemoimmunotherapy.
Why is that?
Because the combination, especially of EGFR inhibitors with the immunotherapy, is associated with substantial toxicity. There was a study evaluating durvalumab, a PD-L1 inhibitor, with osimertinib. They found a rate of pneumonitis, inflammation in the lungs, of about 40%, which is just unacceptable.
Agreed.
And in fact, the toxicity from these immunotherapy drugs can persist after they stop the drug. And so if I have a patient, for instance, with stage 3 disease who has EGFR mutation, I sometimes will discuss not giving them durvalumab where we normally would, because I'm worried that if the cancer comes back, I won't be able to safely administer them a drug that's highly active and usually well tolerated.
So let me be a little controversial here. So say you have a 65-year-old gentleman, never smoker, who comes into your office, gets a biopsy and it's lung adenocarcinoma, and you identify that the patient has an EGFR exon 19 deletion, but lo and behold, the PD-L1 expression is 100%. Patient was a never smoker. Would you give targeted therapy first, or would you consider immunotherapy?
Yeah, so I actually don't think it's controversial at all. I think that we should not give that patient immunotherapy.
Good, I agree. I think that was a little bit of a softball.
Yeah.
Here's my next question, right? So with using osimertinib or Tagrisso, we unfortunately don't obtain cure, right? We always run into, unfortunately, resistance over time. So yes, we improve patients' quality of life. Yes, we extend life. The durability of responses are phenomenal. Now, take it to be a younger patient, a 35-year-old patient, for example. Is there any data, or have you seen anything in the literature looking at combining Tagrisso with immunotherapy? I actually don't think there's Tagrisso, but erlotinib, for example, with immunotherapy. Any data to suggest that with a high PD-L1, maybe you'd get a better response there?
I mean, there's data not in osimertinib, but there was a study that was led out of UCLA,
Correct, yeah.
and so that was led by Dr. Lisberg and Dr. Guerin, and what they did was they said, okay, patients exactly like you described, high PD-L1, EGFR mutation, we're going to give them pembrolizumab. So they did it. And they treated 11 patients, and no one responded. Actually, one person responded, and then they looked back, and he didn't have an EGFR mutation.
Correct, yeah.
All right, so no one with an EGFR mutation responded, and this is where it gets scary.
Toxicity,
Because after stopping the pembrolizumab, there was a patient who died from pneumonitis when they went on erlotinib.
So there's a really nice retrospective series out maybe 2 or 3 weeks ago from Michael Hoffman at Memorial Sloan Kettering, actually looking at rates of toxicity in patients who get tyrosine kinase inhibitors, specifically osimertinib, after getting immunotherapy, and the toxicity is profound.
Yeah.
Right. So I think that's an important thing as a patient, but also as a clinician. When you're talking about different treatment modalities, you're not only thinking about right now, but you're sort of thinking about the future. What can the patient receive down the line? So I agree with you. I think somebody who has a high PD-L1 and also a driver alteration with an FDA-approved indicated drug, I always will give the FDA-approved indicated targeted therapy first.
But there was some interesting data at ASCO last year looking at combining chemotherapy
So that's
in
the
the first line.
IM-Power 150. Do you actually
No,
know
not
which-
IM-Power 150. No. I'm talking about the Japanese study.
Interesting, yes.
So this study combined gefitinib with chemotherapy, and in the first line, not a time of progression, just going up all guns blazing.
That's a tough study because gefitinib is not the commonly used drug in the first line setting now here in the U.S. and most other countries. So I think it's a hard study to extrapolate. And I think if you have a drug that works well, adding chemotherapy on top of that, maybe it'll increase your durability of response, but I think it adds toxicity without much benefit up front, which is difficult. What about that I just mentioned the IM Power 150? That's chemotherapy in combination with immunotherapy, and they actually did show some pretty interesting, data in EGFR and ALK population.
Yeah, so this was a study which was 3 arms, and it evaluated the standard chemotherapy backbone with bevacizumab, a VEGF inhibitor, and the addition of atezolizumab, a PD-L1 inhibitor. In contrast to the other immunotherapy studies, they allowed on patients who had progressed on a prior pill with EGFR or ALK. All these rare mutations probably were in all of these studies. We just weren't excluding. We don't know.
Just to clarify that, the other study, the commonly used prescribed regimen in the frontline setting, the Keynote 189, so chemotherapy and immunotherapy with carbo, PEM, and then pembrolizumab excluded, right?
Specifically
Good.
excluded,
So-
never allowed to be on.
Got it.
And so in Empower 150, they found that there was, in the overall population, improvement in overall and progression-free survival. And then they were intrigued by the fact that amongst patients who had EGFR or ALK alterations, there was a trend towards improved outcomes with the quadruplet regimen. A couple of issues. One, it was not statistically significant.
Agreed.
It crossed over 1 in terms of our measurements, so it was not significant. But it was the first time we saw, maybe this is helping. But it's the only time we looked.
True.
And so I don't believe that that's a magical regimen. I think that it's just the only time that someone's
So
looked.
is it safe to say that you're not giving the quadruplet regimen to your patients with EGFR?
I will discuss it with my patients, and I will say, this is the thing for which we have the most data,
Got it.
but the toxicity of that regimen is much greater than we see with the 189 regimen.
I agree. Any questions from the audience?
All right. Should we adjourn this section? I think we've touched on all the key topics. So I'd like to thank Dr. Sabari. I'd like to
thank Dr. Bauml.
All right, and thank you very much for tuning in through the stream.
I appreciate it, guys. Have a great day.
All right, cool. Thanks.